And Richard, we've got a video presentation for this stage of the debate from Richard.
Good morning, ladies and gentlemen. My apologies that I'm not joining you virtually live. I'm virtually recorded. I find myself in Aberdeen this morning. Right, so when this debate title was first put to me, I wasn't sure who would be foolish enough to attempt to defend this, and it's really very good of John and Elizabeth to put themselves up in this impossible position. But let's move forward. So first of all, who am I? What are my conflicts and my biases? Well, I'm a bog standard neurologist. I'm not an academic. I don't do anything terribly clever. I just see lots and lots of patients. And I was doing remote consultations, as were many consultants, long before our friend here leaked out of a bat in the last year. So I'm necessarily going to present very much a doctor's perspective. I do have some patient data, but I'll defer to Sarah to talk about the patient perspective. Well, let's go look back at this statement. If we're going to be pedantic, well, yes, of course, we could deliver 100% of neurology appointments by phone or video conference. Really, that word should be should, and that's the question, what should we be doing? Well, if we're going to consider remote consulting, we need to think, is it safe? Is it effective? Although we could have an entirely separate debate about what effective consulting might actually be. Is it acceptable to all those involved? And is it achievable, recognising that the NHS and IT go together like fish and bicycles? So straight away, my views are as follows. Yes, of course, remote consulting has a role. I've been doing it most of my career. In my practice, probably around 20%, I would suggest, usually for patients with stable review, patients with history-driven conditions, things like epilepsy, functional disorders, headache and so forth. And you can easily think of all sorts of people that this is unsuited for, those with difficulty with language, learning disabilities, when examination is important and so forth. What we've discovered in the last few months is that actually video consultation adds very little from our end, at least. It certainly adds to the complexity, the IT complexity, and many of us fail. I would, however, be interested to know whether patients gain more from video than necessary doctors. And I go so far as to say that if remote consulting becomes the norm, I'll go and find something else to do. Now, we have found some unexpected issues. You might have thought that the failure to attend rate might reduce if we're chasing patients on the phone rather than expecting them to come to hospital. Well, that's not quite the case. DNA rates have remained pretty much the same. Much of that is just the vagaries of human behaviour. Some interesting technical issues. Lots of people have all sorts of blocks on their phone that they don't even necessarily know about, which prevent us getting through. I think the other problem with remote consultations is it can encourage a less than serious approach. So in the last few months, I've had consultations with people during their weekly shopping, whilst they've been in the car. Last week, someone who'd nipped off to China, and at least one young lady who transpired she was in the bath. Fortunately, not a video consultation in that regard. What about evidence? Well, we do have some evidence from the Association of British Neurologists, who undertook a survey. The initial survey, long before COVID darkened our doors, was about burnout, but we repeated it more recently after COVID and took the opportunity to ask questions about remote consulting. All you need to know there is that this is a fairly large sample. Over 200 neurologists contributed to this. And what you can see, I'll show you some very quick diagrams. The lack of face-to-face consultations led generally to an overall worsening of the consultation quality of care, and that didn't matter whether it was phone or video. The view was the same compared to the normal 2019 practice. If you break it down a little bit in terms of difficulty, generally for new patients felt to be harder and less efficient. You can see here in terms of time, actually overall a rather neutral effect. There is some evidence, as I mentioned earlier on, that it might be more suitable for review patients. If you look at these diagrams here, you can see that actually efficiency seemed a little better with review via remote and less hard, perhaps. So supporting the idea that this is probably more suitable for review patients. We haven't got time to talk about the effect on training. Suffice to say, we're very worried about the long-term effect this will have on the neurologists of tomorrow. So in conclusion, is it safe? Well, we don't really have enough data. It certainly has big training implications, and that will inevitably knock on to long-term safety. Is it effective? We're not entirely sure, but I think if you select your cases carefully, almost certainly, just nowhere near 80%. Is it acceptable? Well, same answer, and I'll be interested to hear what patients view. And is it doable? Well, as long as people answer their phones, certainly. So, John, Elizabeth, I'm sorry, you're going down like a lead balloon. You never stood a chance, but it's very game of you to join in. And I shall now turn over to Sarah Joyner to admit the coup de grace. Thank you very much for listening. I hope to join you shortly.
Richard, thank you for that. Was wonderful. Again, powerful, but also made us all smile, including John as well. So